Good afternoon to one and all. Again, on behalf of the team over at the National AIDS Program Secretariat, we must also apologize for the tardiness in the start of today's session. We've been experiencing some technical difficulties on our end. Sometimes these things happen. But nevertheless, in the interest of time, we're going to start today's session. Welcome to one and all to the National AIDS Program Secretariat Virtual Medical Conference in observance of International STI Awareness Week, commemorated this year from April 13th to the 19th under the theme Talk, Test, and Treat. Allow me to introduce myself. My name is Keisha Chin, medical doctor. I'm the current country coordinator at the National AIDS Program Secretariat for its sexually transmitted infections program. This afternoon, we have a panel of presenters that consists of medical practitioners who have years of experience, and those years of experience have allowed both of our presenters to amass a wealth of knowledge and skills, particularly in offering care and services to persons living with HIV and for persons also affected by other forms of sexually transmitted infections. However, before we go into the two presentations that we have for you this afternoon, I would like to call on the program manager of the National AIDS Program Secretariat, Dr. Tariq Jabnarai, and he will be giving us some brief remarks for today's session.
Hi, a pleasant good afternoon, everyone. I apologize for our technical difficulties and the late start because we couldn't have gotten on and multiple computers we're trying to share. So, as mentioned by Dr. Chin, this week we've started celebrating STI week. It's under the theme get get test, talk, test, treat. So, why is this important to us? Over the past few years, we've been just at National AIDS Program Secretariat, we've just been testing for HIV. Now we've actually established an entire array of new tests. You can not just be tested for HIV in different forms, but we now start testing for syphilis, hepatitis B, hepatitis C, gonorrhea, chlamydia, and even trichomonas. And all of that has been done at most of our VCT sites. And so what we found is that from time to time, we've been treating persons syndromically for STIs. When a person comes to your health facility, you give them that cocktail of whether it's rosifin combined with doxycycline or azithromycin, and you might give flagyl and fluconazole. While that may try to cover most of the germs that would cause an STI, surveillance wise, we wanted to ensure that we can actually identify what are the actual STIs that exist. And we found we started in 2023, 2024. From our data, we're seeing that there is a high prevalence of syphilis. It has been increasing a lot, followed by hepatitis B and C. And so we want to spend this entire week of building awareness of STI by sharing new updated information to you coming out from our guidelines. We do have a guidelines that was established in 2023. The CDC would have updated their guidelines, and we choose to actually adopting that similar guidelines to our setting. And so you'll hear from Dr. Malaika Mutu, who's going to talk a little bit about our guidelines, but principally focusing a bit on congenital syphilis, something that is often neglected within our health facilities. And then, of course, at NAPS, we just don't only try to teach you how to test and treat, but most importantly, our work revolves around prevention. And so we have Dr. Jarek, who is going to share some best practices and differentiated service models that we can use right within our own health centers, our health facilities, to distribute PrEP and increase its uptake as well as PEP. And so without any further ado, I just want to tell you some ground rules. If you do have any question, there is a question and answer section. Just click on that, type in your question. You don't need to put in your name and email address and telephone numbers to get credit. We are doing this presentation as part of the Ministry of Health, excuse me, my apologies, National Health Program Secretariat in collaboration with PANCAP. And so they will be sending you a certificate that indicates that you were present at our session. Once you log in, It will tell us you're here, how long you've been, and how interactive you were. Um, and also, the platform that we're using will generate a list of persons who log in, and we will send that to the respective council. No need to enter into the chat your names. No need to contact us and tell us, oh, you're logged in and you wonder if we got your information. We will. What you can't let us know is if you logged in by chance with multiple persons like Dr. Chin and I we're doing right now, and Dr. Mutu, our presenter, and Dr. Jarek, and Dr. Shivdas. And so without further ado, we will invite our first speaker, hand over back to Dr. Chin, who will invite the first speaker.
So this afternoon, our first presenter is Dr. Nicole Nedjaric. She's a senior medical registrar attached to the Enmore Polyclinic, and she has over 15 years of experience offering HIV and STI care to persons here in Guyana. So over to Dr. Jarek Ned, who is going to be presenting on pre-exposure prophylaxis and post-exposure prophylaxis, expanding access and uptake.
Good afternoon, everybody. Special good afternoon to the staff of the Enmore Polyclinic, some of whom I know are logged in. I trust that you're all doing well. Thank you very much, Dr. Chin, for introducing me. So let's get right into PrEP and NPEP. The main reason we're talking about this is that we want to expand access and uptake. So I'll be looking at touching a bit on the prevalence and incidence of HIV. We'll be looking at it worldwide. We'll also see some trends in Guyana. Then we'll get into what PrEP is, what NPEP is. Then we'll take a look at the uptake, and we'll see finally how we can expand our access and our uptake. So globally, there has been a slight increase in the number of persons who are living with HIV. In 2022, there was 39,500,000. And in 2023, the number increased to 39,900,000. When we look at some of the regional trends in terms of new infections and AIDS-related deaths, we see that there are some differences. If you look, for instance, at the Caribbean, you'd see that we're midway when it comes to new HIV infections. We have a bit fewer than areas like the Middle East and North Africa and Eastern Europe and Central Asia. We also fare a little better in comparison when it comes to AIDS-related deaths as well. However, for people living with HIV, you would see that our numbers are greater than areas such as Asia and the Pacific and Eastern Europe and Central Asia. And this often tells us that, something has to be done. There's good news in terms of the new HIV infections. We would see that there was a drop from 1.4 million to 1.3 million from 2022 to 2023. However, when we check the data closely and we look at the key population, 3 members of the key population, that's gay men and other men who have sex with men, sex workers, and the transgender women, we see that they have a high relative risk of acquiring HIV. In fact, Among gay men and other men who have sex with men, there is a 23-time higher risk, relative risk. Among sex workers, 9 times higher. And among transgender women, 20 times higher. When we look at the prevalence and we compare worldwide with Guyana, among those same key populations, that is, gay men and other men having sex with men, sex workers, and the transgender, usually it's transgender women, we see there is an increase when compared worldwide, when Guyana compares to the worldwide data. So the prevalence is 0.8% worldwide, but for Guyana, it's 1.5%. When we compare and we look at gay men and other men having sex with men, it's slightly lower, it's 7.7%, but the sex workers, it's 11.1%. So this is a key area that we need to address. This data tells us we need to address reaching the members of this key population, gay men and other men having sex with men, sex workers, and transgender. There are some other key populations as well, inclusive of persons who inject drugs, but I did not show that data here, but that also represents another member of the key population. For new infections in Guyana in 2023, we had a 14%, and that was mainly among adolescents and young people, aged 15 to 24 years. And that tells us, yes, indeed, that's another area, not key population, but yes, that we need to deal with. Now, when it comes to our testing and our treatment targets, we know of the 95, 95, 95. We want 95% of persons to know their status. We want 95% of them to be in care and treatment, and we want 95% of them to be virally suppressed. So those are the targets. And it's good for us to get to 95 or even above, even better. So our targets are 95, 95, 95. That's our targets. They're there in blue. Worldwide is in orange. So let's look at that. Worldwide, the number of persons, the percentage of persons who know their status worldwide is 86%. And look at it in terms of Guyana. Guyana is in green, 97%. Wherever you are, you can applaud. We're doing well. Not only did we meet the target, we're a little over, because remember the target is 95%. But look at the other two areas. 95% of persons should be linked to care and treatment. They should be in some sort of service or some sort of facility. Worldwide, that percentage is 89%. But Guyana, that's where we have our lowest number in terms of the target. We're at 72%. And when it comes to being virally suppressed, the target again is 95%. Worldwide, 93% of persons who are HIV positive are virally suppressed. But in Guyana, that percentage is 87%. So of the 95, 95, 95, we in Guyana are at 97, 72, and 87. So that tells us that we have some work to do, and we need to get that work done. And part of the way in which we're going to get it done is by implementing PrEP and NPEP. Now, what is PrEP? PrEP is pre-exposure prophylaxis. So pre says that something happened before. So before you're exposed, you use something to prevent it from happening. So it's the HIV medication that's taken by persons who are HIV negative in order to reduce the risk of transmission of HIV through sexual contact and injection drug use. Now you may ask, does it work? Y'all got evidence of this thing that it works? There are many studies that have shown that PrEP works, that if someone uses the medication, that it shows that there is indeed a reduction in their risk of getting HIV. And one of those studies is the IPREX study. And that study showed that there is indeed a reduction. It showed a 42% efficacy in reducing cases of HIV. All right. Um, it was 44% initially, and then there was an increase, there was a decrease to 42%. So the efficacy was 42%. Now, there are some other studies that were done. I looked up and saw a systematic review and meta-analysis, and they showed some really, really good results. And some of these results were recent. They were recent studies that were done. Some of them were done as recently as 2022, 2023, one was 2020, and they all showed reduction in HIV. The studies were done on the effectiveness of PrEP in several different populations. For instance, among men having sex with men, the study showed a 75% rate reduction. Among serodiscordant couples, it showed a 75% and a 67% rate reduction. The difference was based on the medication that was used. And among heterosexuals, it showed a 61% rate reduction. So all of these studies are showing that PrEP really works. It's scientifically proven that PrEP works, so we really should implement PrEP. I love this from the Ministry of Health, from NAPS, the National Guidelines on PrEP, where it says that PrEP is considered a critical biomedical prevention strategy as part of combination prevention. And one of the reasons that that is so is that it's really, really powerful for anyone who's HIV negative and is in a position where they can go on PrEP. It really works very well in combination with other strategies. So when do we give PrEP? When do we give pre-exposure prophylaxis? There will be some indications. So your partner has to be HIV positive, and you, first up, have to be HIV negative. So the patient is HIV negative, the patient for PrEP is HIV negative, and they can have one of the following four. An HIV positive partner, they can be with a man having sex with another man who has had recent unprotected sex or an STI, people who inject drugs or have recently started a substance use treatment program, or heterosexual men or women who infrequently use condoms and have sex with high-risk partners. So they can be probably like a sex worker, or the partner is a sex worker. All right, so those are the indications. And always remember that the patient has to be HIV negative. So what do we give? What do we give as PrEP? There's one main drug that in our guidelines is used, and that is Truvada. Now, Truvada is a combination drug. Excuse me. It's composed of emtricitabine and tenofovir, and one pill is taken usually at night, but it can be taken at another time with a meal. There is also using Truvada in a setting called event-driven. So it might be a weekend out, a time out when there is the high risk activity. And so there's a special dosing for that. You see 2, 1, 1, 2 to 1 to 1. Two drugs are taken just before you anticipate that you would be engaged in the activity, in the sexual activity that would be high risk. And then 24 hours after, one pill, 24 hours after, another pill. Another aspect, another alternative is to use 2 tablets before, and then for 7 days, continue taking 1 each. Now, the alternative is, instead of tenofovir and emtricitabine, use the combo of tenofovir and lamivudine. But in Guyana, we use Truvada. That's the tenofovir and emtricitabine. And this is available at all care and treatment sites. So this PrEP drug is available for persons to access. And how does it work? Not to be confused by this, but just look to the lower left-hand side. You see reverse transcription. That's the process that Truvada seeks to halt. I always tell people, because I learned this when I started, I was in training for HIV many, many years ago. And one of the things the instructor said to me is that HIV is a very intelligent drug. It's a very intelligent virus. So it works, and there are many ways in which we have to try to stop it because it's so intelligent. So that process of reverse transcription is the point at which Truvada works. So when it works right there, we will not get the DNA copies of HIV RNA and then the multiplication of the virus within the cell. That multiplication is going to be stopped. All right. Now, WHO has some PrEP recommendations, and those recommendations have been adopted in different regions and in different areas over time. And we're very happy that we are part of it as well here in Guyana. We have adopted our PrEP guidelines for a number of years now, and we have been using it. But let's look at some trends in the uptake. Sure, we have adopted the guidelines and we're applying it, but what are the trends and how do we compare? So we're in green and we're kind of way down at the bottom there. You would see the graph, the line is trajecting upwards, but not as high as in sub-Saharan Africa. We know that the stats there are usually very high in terms of prevalence and incidence. So it's good that that's there, but we would love to see our numbers, our uptake go up. So we'd really like to address that. All right, so PrEP. We want to give the patient PrEP and we want to just ensure that they're on it and that they remain negative. There are 4 layers: assessment, counseling and support, and prescribing. After prescribing, after all of that, those 3, we have to do follow-up. And I want you to take keynote because many times issues in each of these areas is often what affects uptake. All right, so ideally, an assessment will check for your eligibility for PrEP, if you have any contraindications, information on the patient's medical and sexual history, and a laboratory assessment. Of course, with the labs, you want to do things like check the renal function because the creatinine is very important, especially when we start the patient on Truvada. We want to check for hepatitis B, hepatitis C. Those are other lab investigations that will be done, but a thorough assessment. And of course, as a doctor in primary health care, I will let you know that it's not just about PrEP and the sexually transmitted infections and so on. You check the entire patient. So this patient might turn out to be diabetic or might be hypertensive or have some other chronic disease. So it would be good to assess and address that. You don't want to just assess them for PrEP and then you start them on Truvada and the patient is a diabetic. And there they are getting side effects and you're thinking it's because of the drug when it's because maybe they're going to hypoglycemia or something like that. All right. So you want to do a thorough assessment of the patient, and included in that assessment is an assessment for PrEP. So secondly, you want to do counseling and support. So you want to talk the patient through the risks and the benefits of PrEP. You want to let them know about combination prevention. So it's important that we stress that PrEP alone does not protect from other STIs. So in addition to using Truvada, the patient will have to layer up with things like condoms and so on, because that's your foolproof method of preventing other STI infections. You'll talk with the patient about medications and side effects. And of course, adherence counseling, which is very, very important, needs to be given. Many times, we know that this falls apart when it comes to several other areas. We have our chronic disease patients who don't take their meds as they should. And surely that can happen with Truvada if there is an issue. So after assessment and counseling and support. And of course, when it comes to counseling and support, you tap into your staff that you have available. So if it's a facility that has a social worker, you can refer the patient to the social worker. If you're comfortable giving some adherence counseling and that kind of support, you give it. If there is a navigator in place, you can refer to the navigator. If there's someone you can send the patient to, really that's very important. But just know that adherence counseling is important. So after assessment and counseling and support, that's when you're going to prescribe the medication. Now, we just spoke about the drug. We spoke about the event-driven PrEP. There's a name for it later on in the presentation, I'll tell you. And then you want to assess for comorbidities and possible drug-drug interactions. So like I mentioned before, this patient may be a chronic disease patient, or it may be a patient who is on other medication for whatever reason. It might be a young person, that person might be asthmatic, and so on. You'll need to go through their medications, check in with them, look for possible drug-drug interactions, and be able to prescribe based on that. So once you get the go-ahead, the green light that you can, then you go right ahead and you give the patient the PrEP. So we've assessed them, we've counseled and provided support, and we're providing them with the medication. We're not just going to drop them and leave them in the ocean like that. All right, we need to continue with adherence counseling. And based on the meds that you give and based on the patient you have in front of you, you might comfortably be able to say, listen, I'll see you back in 2 weeks. Let it not be fixed in stone that you say, all right, this patient has to come back in 2 weeks. You might get a little bell going off and you might say to them, listen, can you come back on Friday? Or can you come back in 2 days? Can you come back next week? Because you may still want to talk with the patient. You may not have been able to get something done, maybe a particular lab investigation or so on, and you have days at your clinic. At Enmore Polyclinic, for instance, we offer lab services 2 days in the week. So for anyone living in the community, it's easy for them to come across. So you may see the patient on a Monday and you tell them to return for labs the following day. And you may ask them to see you as well, to ask them, you know, how are you doing? You took the pill just yesterday. Any issues, any side effects or so on. And you want to always ensure that you follow up. Follow up is very, very important. As I mentioned, each of these pathways and each of these in the care pathway, any of the areas we can fall apart in terms of the assessment, not doing a proper assessment, not sending the patient for counseling, adherence counseling, not really prescribing when we should or early enough, and then not following up. So we want to ensure that in every aspect of this care pathway, we follow up with the patient. All right? I nearly said any questions. Okay, so that's PrEP. That's pre-exposure prophylaxis. We're now going to look at non-occupational post-exposure prophylaxis. So PrEP is before you're exposed, you're taking the meds. In PEP, it's after the exposure. So non-occupational exposure, the other type of exposure is occupational. So non-occupational refers to exposure to the infectious agent, HIV in this case, that occurs outside of one's work. For example, during sex or when people share needles to inject drugs. So we're talking about HIV specifically here, but of course, you can also, it can refer to any other infectious agent, hepatitis, or any of the STIs, chlamydia, gonorrhea, or so on. But we're specifically, for the purpose of this presentation, referring to HIV. So occupational exposure would mean within the setting of your work. So that's like when the nurse or the doctor gets a needle stick or that kind of exposure. Here, we're talking about non-occupational. So NPEP, or non-occupational post-exposure prophylaxis, is short-term HIV treatment started as soon as possible after high-risk non-occupational exposure to the virus. Now you notice some keywords there, right? High risk is one of them. And there are some areas in which I think it's here that you will know whether it's high risk or not based on the transmission rates. All right, so we just spoke about PrEP and we talked about PEP there. Don't want you to get confused. PrEP is pre-exposure, so that's before the exposure, and that's the medication you take before. So it can be taken every day, and it's based on whether you're going to engage in risky sexual behavior and so on. You anticipate that and you can use it. PEP, on the other hand, is medication that's taken after exposure to HIV. And so, in effect, it's like an emergency medication. All right, that's the difference. So, I was talking about the types of exposure. Let me just go back to that slide. When I mentioned NPEP, non occupational post exposure prophylaxis, and I spoke about it being used possibly after high risk exposure. Now, this table gives us the type of exposure and the median risk of HIV transmission per exposure. And if you notice, receptive anal intercourse is way up at the top. So when you're doing your history in the care pathway of PEP, that's post-exposure, that's after the exposure, these are some of the questions it would be pertinent to ask. All right, so how were you exposed? Was it oral sex? Was it vaginal sex? Were you the recipient? Was it receptive anal intercourse? Receptive anal intercourse, that one is way up at the top in terms of risk of HIV transmission. And that would tell you that's the highest risk. And so you definitely have to start the patient on post-exposure prophylaxis. And here are some recommendations. And the first up is that you start as soon as possible after exposure. Ideally, it says there, within 2 hours. But it's not till you have up to 72 hours to give a patient NPEP. So ideally within 2 hours, hopefully, whether this is a sexual assault or whatever it might be, ideally within 2 hours if we can start on PEP. But if the patient comes to us 72 hours after the exposure, research has shown that PEP will not be effective. At the point at which you're seeing the patient at baseline, there needs to be an assessment for the eligibility on the HIV status of the source. And so you test the exposed person to see if they're HIV negative, and if they're negative, then you offer PEP. Of course, if someone comes in and they reveal probably, let's say there was sexual assault, but when you test the person, they come back positive, that person is not for PEP. That person is for care and treatment. And so they would have to be referred for care and treatment. Remember, in order to use PEP, you have to be HIV negative. All right, so let me just recap there with the recommendations. Ideally, within 2 hours, but you have up to 72 hours to treat the person with PEP. And you need to determine the HIV status of the source person and the exposed person. If you know the HIV status of the source person, you know for sure that it's negative, you will not necessarily have to offer PEP. But if you know that it's positive, or if you're unsure, you offer PEP. And then the person who is exposed, when they come to you, if they're negative, you offer PEP. But of course, if that person is HIV positive, you have to link them to care and treatment. Now, what do we give? We give a combination of Truvada and dolutegravir. That's GRAVIR. So a combination of Truvada and dolutegravir. Sometimes the tenofovir is combined with lamivudine along with the dolutegravir as the drug that is used. But we usually use the first. So here's the care pathway. And we would notice that it's quite similar to that of PrEP. First, you do your assessment. Second, counseling and support. Third, prescribing, and then the follow-up. So in the assessment, same thing. You will assess for the person's eligibility for NPEP, see if there are any contraindications, check in on the patient's medical and sexual history, and do the laboratory assessment, which is important. And then, of course, counseling and support. You let the patient know about the risk and benefits of NPEP. You're providing them with medication. They have to know about side effects. They have to know how they need to use it and the best time and so on to use it. And then, of course, we would prescribe it based on their drug history. So if they're on other medications, you check to see if there are any conflicts in terms of the drug-drug interactions, and you want to rule that out because you don't want the patient to go on the medication and then have additional side effects. And then, of course, follow-up is important. So we see them back again, follow up for counseling and checking in on the drug and side effects and considering if we need to offer them PrEP as well. So this might be a patient who might come in and might say to you at the beginning, you know, I had sex with somebody who is HIV positive, and you start them on the treatment. And then a month they come back and they're like, I'm still with the person. I need some more of this medication. So right away, you know that that patient needs to be offered PrEP once they're still HIV negative. That's not a case for PEP. PEP is more of an emergency drug situation. All right. And with PEP, the patient is given the medication for 1 month, once daily for 1 month. In evaluating and treating patients with non-occupational exposures, this is a really nice algorithm and guideline. So if there is someone with substantial risk and they are within the 72-hour period, we check to see if they're HIV positive or negative. So we check the HIV status. If the person is negative, then we would offer the person NPEP. NPEP is recommended in that case. And if the source person, we don't know the status of that person, we can still offer, but of course, it's on a case-by-case determination. All right. If it's more than 72 hours since the exposure, then PEP is not recommended. And so we still have to do an evaluation, check the patient, you know, check them for other areas in terms of exposure, check them for other things. We have to examine the patient as well and so on, and treat them possibly. And they can be checked for other infections and so on and be treated for that. But in terms of PEP, in terms of post-exposure prophylaxis, it would not be recommended after the 72-hour period. All right, so you've had a mouthful about PEP and PrEP, pre-exposure and post-exposure prophylaxis. The question is, because at the beginning of the presentation, I started by saying, you know, we have issues among the key population, key populations like men having sex with men, sex workers, and transgender. And so it's important that we seek to expand access and uptake of these drugs. So basically, how can we get it out there more? We even saw on the graph that our uptake can improve. So how exactly do we go about expanding access to these drugs and increasing our uptake? We have to get over the barriers. And there are some barriers. Persons not aware of their risk. They don't know what's available. They don't have proper access to care. They have issues with stigma, issues with adherence. Providers are often unaware of their interventions, uncertain how to deliver it, don't even know about the complexity and time. And so when they get into it, they become worried. And then oftentimes discomfort with the assessment because it's so detailed and of a sexual nature. So if we can look at all those areas, we can find implementation strategies and reasons and ideas for us to improve access. So in terms of complexity, Many times, PrEP initiation and maintenance is challenging for patients and providers. They would need multiple visits. As I mentioned, at NMO, we don't do blood work every day. So, the patient will have to come back for blood work. Remember, many of them might be working. They have to ask for time off, the distance to travel, and so on. And so some of the proposed implementations would be same day initiating PrEP. So when you see them, you do your assessment and everything, you initiate PrEP, and then you have them come back with the other areas that you want to target. So you have a flexible regimen. You tell them, all right, I'll give you this amount. I want to see you back in 2 weeks. Let me know what's happening. Because remember, PrEP especially requires ongoing follow-up. And another thing about the follow-up is that we can make it simpler. So incorporate the blood work with the clinic appointment. So if we want them to return in a few days, give them the day when it's going to be the day when the phlebotomist comes to the clinic and the patient can have blood work done. And of course, we can tap into family support. And this would tell us a lot. This would tell us about how much the patient has disclosed to their relatives and would let you know that they can have a strong support base going. All right. When we look at misconceptions that the patient might have, they might tell themselves that they don't perceive the need for PrEP. They don't even think that it's relevant and that they need to use it. They might confuse PrEP with art, and they might say, you know what, if I use this tablet, it'll be a whole set of side effects. One of the studies that I saw, I cannot remember the African country. One of the studies, one of the misconceptions that the patient had is that they said that the government was trying to make them become HIV positive by offering the PrEP to them. So these are all these are all misconceptions among patients. And so it's important that we help the patients to understand. Peer navigation is one good way of going against that. Repeatedly offering a patient PrEP. So you may have, for instance, a discordant couple. So you have someone who's HIV positive and one who's HIV negative. Every time you see them in the clinic, you encourage the HIV negative partner. You say to them, it would be good if you can go on PrEP, and you show them the benefits and so on. And mind you, there are some persons who are knowledgeable about it, who read up. I remember even before PrEP came and was implemented in Guyana, one of my discordant couples, the HIV negative guy, he was asking about PrEP. I remember that actually was the first time I'd had the discussion with a patient, and I was talking with him and telling him it's not yet in Guyana. So we can have these discussions with our patients because it's here now. Increased STI testing, because when we test for STIs, we find the STIs, we can link the patients to care, and then we can offer them PrEP. And of course, PrEP education, and then following it up with monitoring and evaluation. Now, what about stigma and poor health literacy? Stigma is a big one. There is a stigma against key populations, and so it would rub off, as we would say, on the partners many times. Patients are unwilling to walk around with a bottle that has Truvada. Everything. People go to Google these days. They would look at it and say, this boy, see this boy drinking this tablet. And you Google it and you see it's for HIV, like he got HIV. So patients might not want to show up at the facility to get anything because of the stigma. And so we can, that can be dealt with. We can streamline their visits. We can have targeted media campaign messages. I like the ones that we have out already. We can do more. We can get into other areas because social media is really very powerful. And of course, targeted intervention. So we deal with this particular case at this particular time. And of course, integrating health information into all our health systems, whether or not they offer PrEP and PEP. So it might not be a care and treatment facility, but we can still offer them PrEP and PEP education. That would still be important to them. Access to care. When patients come, they have a very long wait. They have difficulties getting to and fro from the health facility. When they get there, there's a stock out of the medication and they're unable to get it. And so we can implement by having fast track systems for PrEP and NPEP. So we know that this is our PrEP patient. And once the patient comes in and is triaged, we can have a system in place where, the patient is fast tracked because they're just coming for a follow up and they're just coming maybe for a refill, and we ensure that they get that. We can also try to create a seamless transition. You have to be very careful, however, in facilities that offer care other than HIV care and treatment, because you don't want it to appear as though this particular group of patients, yes, they're getting this treatment, but what about us? Why is it we weren't weighed? And why is it, we didn't get to go in front? So you don't want questions to be asked. You want it to seem very seamless, as I mentioned. You want the transition to appear to be seamless. And of course, we need to link them with other healthcare services like family planning and the social worker. Many times, our social worker at the Edmore Polyclinic, he deals with our HIV care and treatment for patients first. So when they come, whilst they're waiting to see the doctor and so on, after having triage, they can go to him, have their consultation with him. And so that helps to ease the waiting time. NAPS has something called the lash bags, and those were out. I saw it for the first time during MASH. I did mention PrEP and the immediate care of using it two days before you plan to engage in risky behavior, and then using one and then using another one 24 hours later. And the bag is a complete product. So you don't just have the medication in it, there are condoms and there are all kinds of other things, flavored condoms as well. So it's a nice little complete package. Of course, we have the public-private partnership and telemedicine that can deal with where, the patient wouldn't have to get out of their house, call a taxi and all of that, and it would be very easy for them. And finally, poor adherence. So the patient might come, go on the treatment, and for whatever reason, they might be having side effects. They might have an issue when they went home. Somebody saw the medication, pill, bottle, whatever reason, they would stop using it or not using it as they should. And there might also be issues with the efficacy of the drug. That is reduced whenever there is poor adherence. And so for this, the case navigators are important. If you have a social worker, it's good to put your social worker on this. If you don't have a case navigator, it's important that the patients have reminders. And there are several ways in which they can do it: an SMS message, they can put a timer. I always like to tell persons that I had one patient tell me that every time a particular news broadcast comes on, that's his key to go take his medication. So if you know that, or maybe death announcement, well, it depends on your age. It depends on what you would use, and that can tell you that there is this is to tell me that I need to take my medication, or the patient needs to take their medication. And of course, there are some newer drugs that are out, aren't in Guyana as yet. And I know that for PrEP especially, this newer drug, cabotegravir, it's an injectable and it's given every other month. I'm sure that if we offer something like that to our patients, that they would tend to think of going with that as opposed to drinking a pill every evening or every day. They would see it as cumbersome and so on, and it would be better for them to take an injection and know that they're fine it, at the end of a month. That drug can also be injected, given every 2 months as well. So these are all on the horizon for us, and hopefully we can implement all of these in order to improve access and uptake at our various facilities. Thank you very much. I'll take your questions if you have them.
Thank you so much, Dr. Jarek. So far, there are no questions in the chat. Well, I just seen they now start putting questions. So I'll share the
Oh,
questions. Um,
Uh, 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 just a gentle reminder before I share the questions. If you have any queries, anything, comments you want to make, any questions to Dr. Jerrick's presentation, kindly click on the question mark icon. It's your question and answer, where you can share your questions, and we will try to answer as much as possible. So starting with the first question, so we have, what if I get a needle stick? What treatment would be best recommended?
It's the same treatment as is given for PEP in cases of non-occupational exposure. So you go to the clinic and it's the same thing. Like I said, this presentation focused on non-occupational exposure, but for occupational, which would be the needle stick, it's the same drug. So it would be good after initial reporting at your facility. Let's say your facility does not offer care and treatment, you have to do follow the protocols. So it has to be reported at your facility to your supervisor. Nurse in charge, I was stuck with a needle by this patient. And she would say, okay, the nearest facility is Enmore Polyclinic. When that nurse comes over to the Enmore Polyclinic, we go through the same thing. We do the assessment, and then we determine, yes, this is a nurse, we're going to start her on PEP. We start her on the medication. It's the same thing as if it's as in the case of NPEP. So it's the same medication. Thank you.
Question, Dr. Jarek. Don't go. You have about a dozen more, but that's okay. We have time. I'm just kidding.
That's right.
Um, so we have another question that says, can someone use both PrEP and PEP together?
The thing is, that would not be necessary because PEP is used like in an emergency situation. And if you're already on PrEP, you wouldn't need to use PEP. All right, so let's take a scenario. You have a partner who is HIV positive. He was out of the country and he is coming back in 2 days. So you start on PrEP. All right, you start using PrEP. And then you say, you know what? I am going to use a condom as well. But he said, no, he doesn't want you to use a condom. And so you're exposed to HIV as a result of the sexual activity that you have. Are you thinking therefore that, this is what happened? Do I need to also take PEP? No. So you don't, no one needs to take PrEP and PEP, no matter what the situation. If you're already on PrEP, you continue using PrEP and there's no need. Only if you're not on anything, you're HIV negative and you're exposed, then you go on PEP,
Thank
post
you, Dr.
exposure.
Jarek. I just want to add to that, if for some reason you would have been on PEP for a post-exposure, where your condom bursts, non-occupational exposure, I must specify, the condom bursts or whatever reason, and you know you're generally risky, you're engaged in risky sexual activities, while you start that PEP for the exposure, you may want to see and consider transition into PrEP afterwards, especially if you have multiple partners, you don't use condoms, and whatever you use IV drug use. There is another question. There's so many that is coming in, but let me try to go back to the one that was missed. Can you share some side effects of PrEP?
PrEP, pre-exposure. Actually, there are not very many. Some patients come in with headaches and dizziness. Often that's what we get a lot. And so I usually tell the patient to take it in the evening. Sometimes drowsiness. There are other side effects that are listed. These are listed side effects, how it can affect your liver, kidneys, and so on, and how you would feel. But often we don't get patients complaining of that. But of course, those are the listed side effects. But most common is dizziness, drowsiness, and a headache. And usually, we in the adherence counseling, when we tell the patient about the drug and using it, we tell them to expect this. And so we are able to tell them, take it at night, and you would find that by the time you sleep it off, you wake up in the morning, it will have abated. And not just that, for the patient to continue using the drug despite those those side effects, because the side effects would eventually go away. All right.
Thank you, Dr. Jerick. Another question popping up says, as a nurse, what are some of the best ways and suggestions I can give to my patient about their status and mechanism to cope?
Say again, and mechanism to.
To cope. Coping mechanism, I guess,
Oh,
if
to
they're
cope. Oh,
positive.
mechanisms to cope. Oh, all right. Well, if I'm hearing that it's a nurse who has to tell the patient about their status, I'm taking it that they probably don't have a social worker on site. Um, because I always, that's one of the reasons I love social workers. Some of these things that we know we have issues and difficulties with, we ask them to deal with. And the thing is, they are trained to do it. They are trained to let the patients know. The VCT counselor tester as well is trained to provide that counseling. But as a nurse, you may have to deal with the patient in the aftermath. So they've been tested, and then of course they have to see you for whatever reason. Oftentimes it's very simple. You take it simply. You can take that patient aside and you just sit and you talk with them. You can ask them, what do you want to know? What do you want me to tell you about HIV? What do you want me to tell you about your status? You know, things like that. Who are you living with right now? Have you told any of them? Why do you not want to tell? I find that disclosure is really low among patients. So you tap into them based on what you think their needs are, and you let that patient know that you're someone that they can confide in, and you're to encourage the patient to keep coming for care and treatment no matter what. I find that that works. That has worked for me, encouraging the patient and tell them, you know what, I don't want you to stop coming. I don't want you to stop using your medication. Sometimes you have to risk giving them your number. I say risk because it's really not usually recommended. So you can have them, you can assess the patient and determine if this person is fairly intelligent enough and would get your number and wouldn't abuse it. I've had patients like that. And so you talk with them, and as you talk them through, that would help them to be able to cope with dealing with it. There are a number of persons as well who will deal with it differently. Remember, young people will not deal with it as much as a 40 something year old. Someone who felt they were cheated on and got the virus will not take it nicely as well as maybe a man. So you have to assess your patient as well. But thank you to that nurse for asking, and I hope that they can reach out. And remember, you can reach out to anyone at NAPS, any physician, me, anyone else, in order to get help to determine how best you can approach that. But I would recommend a social worker for the facility for the person.
I have a lovely question here from one of our participants who is asking, how many minutes or hours do you need to take Truvada before having a wild night out? And so definitely, based on the recommended guidelines, we would suggest that you take it 2 to 24 hours before you're involved in
Yes,
any risky sexual behavior. Saying it
yes,
once again, 2 to 24 hours, and so you're
yes,
fully covered. So you can't take
yes,
the tablet now and then expect to go and have any kind of wild night out as you suggested and expect it immediately work. Um,
yes.
and then there's a lovely question here. Any contraindications for PrEP when it comes to some diseases, especially like autoimmune disease? You want to go or I
Contra,
can go?
no contraindications. You would have to review. It's not just about the disease itself, but you need to review to see what medications the patient is on and how long the patient is on their medication. Many times when you have autoimmune diseases, the patient cannot just stop what they're on right away. It has to be tapered off. And so it's important that you know what they're on, see if it has to be tapered for a while whilst they're on the medication. But other drugs, to my knowledge, things like steroids, methotrexate, and so on, they're not contraindicated. And so the patient can go on it. But like I said, for the patient, you're on that. It's good to indicate it to the doctor, especially if the
Yes.
doctor doesn't ask.
Yes, absolutely. That's what I was going to add. Once you do have an autoimmune disease, you would want to tell your clinician, your primary care clinician that you're dealing with. Most importantly, especially those autoimmune disease that has to do with your intestinal tract. There have been some reports, but it's not corroborated as evidence-based studies that PrEP can change your your gut lining and your
The gut, yeah, gut lining.
microbes within the gut. And so if you do have issues with irritable bowel and inflammatory diseases, you would want to tell your clinician and work with your clinician, but it's not contraindicated. You can use it. Dr. Jarek, I know you're answering so many questions. Don't go. We have Dr. Mutu on standby, but I have two more questions. I'll share both with you, and you can respond, and we then will prepare for Dr. Mutu. There's so many that are coming in. How so one of the question is where are the closest facilities within Georgetown that I can go to if I get a needle stick? That's one question. And the next question, how long is it safe for me to use PrEP? Um, can I use it continuously for over a prolonged period? And last, coming into that same question, what about expiration dates of drugs? Because I think PrEP is available in Guyana. Currently, most of them are expired. I'm not aware of that, Ryan. As the head of the National AIDS program, that would be news to us. But uh, yeah, back to the two questions, Dr. Jarek. Where is the closest point, and can someone use it continuously?
Or, camera. Oh, oh, sorry, I was muted. I'm not Georgetown based, but I know some of the care and treatment facilities, Dorothy Bailey, Camerville. Camerville has recently moved physically because they're undergoing upgrading. Uh, the National Care and Treatment Facility is Festival City one as yet. Festival City. All right. And the thing is, if the person needs to really get information, they can go to any of the health centers or facilities in Georgetown, and they would be recommended to the one that offers PrEP. In terms of how long it can be used, it can be used continuously. I saw one study reviewing after 5 years. That person was with their partner, the partner's positive, and they were negative. They're negative and on it, and needed to continue on it because, of course, the partner is there all the time. Um, Such persons have to be constantly reviewed, and it's important that even if you're not using it for that long, you still need review and follow up. All right, so it's important that it is used and that you're followed up. But I've not had a patient who has been on it for that long, but it can be used. And like I said, you have to review. You have to ensure that a review is done, a review on a regular basis. I think the other question you addressed, Dr. Jack Ryan, about expiry, just know, folks, that drugs have a shelf life. And remember, when we procure these drugs and we have them available for the patients, it's not that, okay, it expires on 28th February, and so on the 29th of Feb, on the 1st of March, we dump all of the drugs. They're still potent, they still can be used, and so we can still offer them to you. What I usually do, if I ever am in a position where I have such drugs and I don't have the newer ones as yet, I talk with the patient, because if you just sit and you say to the patient, all right, here's your PrEP, it's good for you, la la la, these are the side effects, and they go home, first thing some patients do, they check for the expiry. They'll be like, wait a minute, Dr. Jerry talking to me so nice, and then give me drug that expire. So it's good to tell the patient, listen, you see here, it has expired on this date. It's still good to go for another 3 months. In terms of what is in the system right now, I will not be able to speak to that, but I would say that once it has 3 months, yes, you're good to go.
So in terms of the system, we do have large quantities and adequate supply of PrEP. Not just Truvada, we also have, like Dr. Mentioned in her presentation, the Truvada is a two ARV combination, etracetamine combined with tenofovir disoproxil. We have, however, that tenofovir, it can affect kidney function. Not generally damage your kidney, but if your kidney is already damaged, there's an issue with clearing that drug. And we do have an alternative, which is the TAF, which is tenofovir alafenamide, and it's available with large quantities in Guyana. There's a lovely question. I'm going to answer it quickly, and then we're going to go to our next presenter. I'll hand over back to our moderator. Um, how many days is the concentration of PrEP in your body? I want to mind you, I see Garfield. Brian, you asked that question, and I'm assuming as a healthcare worker, we try not to tell patients about this because they have a tendency to feel that they can miss their drugs,
Stop.
and it
Yeah.
contributes to miss system treatment failure sometimes. While etracetamine can stay as much as 10 hours within your body at the plasma level, and even from an intracellular level, you can get it about 32 hours. We still tell persons you have to take your pills daily. Please don't miss your
Daily.
drugs.
Yeah.
And so you did ask, is it there's a difference in terms of male and female? There's a propensity that yes, there's some studies that show that male and female that pharmacokinetics of the half-life of PrEP is quite different. But at the end of the day, please encourage your patients to take the meds daily. We will answer. There are so many other questions in the chat, but we're pressed for time. We will answer your questions directly. Please look out for the answer in the chat. I hand you back to our Madam Moderator, Dr. Chin.
Thank you.
Thank you, Dr. Jagnaran, and a big thank you to Dr. Ned for her very insightful presentation. Definitely your knowledge and your passion on all things related to PrEP and PEP has definitely added value to today's discussion. And in the interest of time and without further ado, I would like to welcome Dr. Malaika Mutu, pediatrician and neonatologist attached to the St. Joseph Mercy Hospital and the head doctor for the Capital Family Health Clinic. And Dr. Mutu comes to us with excess of 20 years of experience offering HIV and STI care. She's definitely incomparable when it comes to all things HIV. Over to you, Dr. Mutu.
Thank you very much, Dr. Chin, for this very gracious introduction. And thank you very much to Dr. Ned for an excellent presentation. It's going to be a very tough act to follow, but I will try my best. And thank you very much to everyone at NAPS, Dr. Chin, Dr. Shivdas, and Dr. Jagnarayan, and all the other staff for inviting us to be a part of this CME session. We're changing gears a little bit here, and we are moving on to the elimination of mother-to-child transmission of syphilis. And, so I know we're running behind, so I'm going to try to make this as brief as possible. Okay, sorry. Okay, I'll get the hang of this. So my objectives are here. We just want to review the current syphilis screening guidelines in pregnancy and discuss a little bit about understanding those test results, and then review some of the CDC recommendations for congenital syphilis testing and treatment. As you all know, there is a triple elimination initiative that is a WHO initiative. They have encouraged many countries, and we are one of them, to commit to the elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. And this is just a little algorithm of the things that we are expected to do. So we test women in antenatal care for HIV, syphilis, and hepatitis B. We try to be prompt and efficacious in our interventions so that the women who do test positive are treated quickly and effectively so that they don't transmit to their unborn children. We, of course, include partners, or should be including partners in all of the counseling, so that we can also treat the partners and help to reduce transmission. Dr. Ned already spoke to us about discordant couples and how we can effectively reduce transmission to them. And because we're dealing with pregnant women who have some type of a infection that can be transmitted to their infants, we have to also discuss and make sure we make arrangements for appropriately safe deliveries. Then, of course, there's follow-up of the exposed infants, including giving them the birth dose of the hepatitis V vaccine, which we are doing in Guyana. Then the discussion about optimal infant feeding, and of course, follow-up treatment for the mother, and testing for the infant as well. So we're talking about syphilis today, and as we all know, syphilis is a systemic bacterial infection, and it's caused by a spirochete that is called Treponema pallidum. It's actually have been dubbed the great imitator and the great mimicker because it has so many signs and symptoms that mimic a variety of different illnesses. So you really have to be on the lookout for syphilis and to keep it in the forefront of your mind. Dr. Ned said that the HIV is a smart virus. I think syphilis is the great chameleon. It hides itself all over the place. So syphilis has come to the forefront for everyone because these are just a few articles that I've highlighted here. One from the New England Journal of Medicine that talks about the rise of congenital syphilis in pregnancy and the rise of congenital syphilis. There is one from the American Academy of Pediatrics that talks about the rise in congenital syphilis, which of course is a huge concern worldwide. WHO highlighted that we in the Caribbean have had a surge in syphilis cases, and it actually went to legislation in the US because it is of great concern that the rise in syphilis cases and the rise in positive syphilis results in pregnant women. This next slide shows you some data from WHO PAHO, and it was for 2022. And it showed that in that year, at the end of that year, there were 8 million cases of syphilis globally. And this was mainly between the age groups of 15 and 49. What was a little alarming is when you look at that 8 million cases, 3.36 million of them were actually in the Americas, which is actually more than 40% of the cases, which is a huge amount of cases. And even more alarming is that it was a 30% increase from 2 years prior in 2020. Out of those many cases, there were 183 pregnant women with syphilis and 68,000 cases of congenital syphilis. And we will talk about congenital syphilis because it is really a terrible illness. Syphilis is one of these infections that has many stages. From exposure to tertiary or late syphilis, you can actually have decades, maybe 4 decades or 5 decades in between. So after exposure, you can incubate this for up to 3 months, and then you enter into a primary and then a secondary stage of syphilis. And this will all happen more or less within 6 months of your exposure. The primary and the secondary stages of syphilis are actually the most infectious stages of this disease. And that is why early detection and early treatment is very important. After the secondary stage, it goes into a latent phase, which has actually two phases, an early and a late latent phase. And the early latent phase, what is interesting about it is that patients can actually have a recurrence of second stage to second stage because they can get reinfected and they can actually go back a stage. Good to note that neurosyphilis, ocular or otic syphilis can happen at any stage of the disease. And transmission to the fetus during pregnancy can happen at any stage of the disease. It can happen from early to late stages. As I said before, it is the great imitator. It has many different appearances. And these are just some lesions that we see in the first 2 stages of the disease, the primary and the secondary stage. Like I mentioned before, the primary lesions will happen anytime from 1 week to 3 months after exposure. And they're usually small, firm, painless lesions, and they happen at the original site of infection. So either on the genitalia or on the mouth or on the tongue. The second stage is where things tend to vary a lot. So you can have the mucus patches on the tongue that can sometimes be misdiagnosed as lingua geographica, but these are actual mucus packages. They're round, they're distinct, they don't look like the lingua geographica, they're highly contagious. You can have the condyloma lata, which are the wart-like lesions in the genitals. They have a high accumulation of spirochetes and highly infectious. Also, you can see alopecia. The alopecia has what they call like a moth-eaten appearance, so it's kind of like patches all over the scalp. And then, of course, the rash, which is the most common symptom that we see in the secondary stage. It is a macular and it can be also a papular rash. It is non-itchy and it can appear about 2 weeks to 12 weeks after the initial painless lesion that was seen. Many times I have to say the painless lesion goes unnoticed. The rash is really important for us to, when you see a rash on an adult who is sexually active, to always bear in mind that this could be syphilis. So whom do we screen and how do we test? So first of all, you can screen, there are two types of patients we can screen, the symptomatic and the asymptomatic. And I want to say again that the symptomatic, for the patient that we consider to be symptomatic, bear in mind that any ulcer, regardless of its location, any ulcer that is painless, that is indurated, and it doesn't heal within 2 weeks, think syphilis. And any generalized skin rash that you see, doesn't matter what it looks like, what its morphology is, please consider syphilis until you can prove it otherwise. For the asymptomatic patients, of course, we screen all pregnant women and we screen anyone who we consider to be in a high-risk group. And how do we screen them? Well, there are two different types. There are two tests that we are familiar with here in Guyana, but there are other tests as well. So there are the serological tests that we're familiar with, and then there are also the direct methods for diagnosis. That would be the PCR or the dark field microscopy. The tests that we use are the non-treponemial and the treponemial tests. This next slide, I put it in because it actually helps me a lot. I find it really important to understand how to interpret titers because this graph kind of helps to see how they change with infection over time. So if we look at the treponemial titers, and the treponemial titers would be the antibody titers, remember that they stay positive forever. So if you look at the graph, you can see the treponemial titers are the ones with the dashed blue line. So there's a treponemial IgM that of course comes up first, and then the few weeks later the treponemial IgG comes up, and it always remains positive. So when we do the treponemial tests, we will always see antibodies present, positive for antibodies. It doesn't distinguish, because it is always present, it doesn't distinguish between a past or a current infection, nor does it tell us whether treatment was successful. The non-treponemial titers, they go up with infection, and that is the more solid line that you're seeing there, and they decline over time, both with and without treatment, interestingly enough. But you can see that without treatment, which is the fainter line on your graph, the titers still remain somewhat high. With treatment, they should decline and decline all the way down to non-reactive. So we use these titers to distinguish between past or current infections, and of course for treatment success. So this is the traditional screening algorithm, which is the one that we use here. And that is that you screen with the non-treponemial test, which would be the RPR or the VDRL. And we confirm that with with a non-treponemial test. So we confirm the reactive non-treponemial with a treponemial test. So we use the RPR, the VDRL. If it's reactive, then we go ahead and we do the the then we go ahead and we do the treponemial test. If it's reactive, then it's either current or a prior infection. If it's non-reactive, that it's unlikely that it's syphilis. So for example, you can have somebody that comes back with an RPR 1 in 1, they put in brackets neat, but the antibodies come back negative. So then would be a person who is unlikely has syphilis. However, I do want to mention that early primary syphilis and late untreated syphilis, it is possible in those cases that you'll still get a VDRL that is non-reactive. If you suspect that your patient is high risk, even if if their tests come back negative, or you think it's unlikely that they have syphilis at that time, remember they can incubate it for a long time, and as we saw on the graphs, it might take 1 or 2 weeks before we actually see titers rise and we see antibodies present. So if you think that there's someone who's high risk, they've probably had been exposed to syphilis because they've had condom-less sex with an unknown partner, or maybe with multiple partners within the last 1 or 2 months, then consider a repeat test within 2 or 4 weeks. How do we treat syphilis? So primary, secondary, and early latent syphilis is treated with benzathine penicillin, 2.4 million units IM in a single dose. Late latent or infection of unknown duration, or tertiary syphilis but with a normal CSF examination, we use the same benzathine penicillin. We do the 2.4 million units, but we do it once a week for 3 weeks. So they get a total of 7.2 million units of penicillin. So this is actually what I really did want to talk about, and this is congenital syphilis. So we know that congenital syphilis can affect the pregnant woman and her unborn child in many ways. Miscarriages, prematurity, brain and nerve damages, bone damage, low blood count. Congenital syphilis is something that has really been on the rise. In 2022, WHO estimated there were 700,000 cases of congenital syphilis globally. I mean, this is just a staggering statistic, because we all know that congenital syphilis is severe, it's disabling, it's often life-threatening, and we also know that syphilis can be treated, so it doesn't have to pass on to the unborn child. So the maternal syphilis cases that were seen in 2022 resulted in 150,000 early fetal deaths and stillbirths, 70,000 neonatal deaths, over 50,000 preterm or low birth weight infants, and 115,000 infants with a clinical diagnosis of congenital syphilis. I mean, these are all really sad statistics, because we know that this could have been avoided. This is just a little bit of data I got from our colleagues at the Maternal Child Health Department of Ministry of Health, and that is syphilis in pregnancy in Guyana in 2023. We had 162 syphilis reactive pregnant mothers. Most of them were successfully treated, because we only had 2 infants who were syphilis reactive. So that even though we did have a high number of cases, we had a very good success rate. So syphilis can be passed on in 2 ways: sexually or transplant from mother to child, so transplacentally. It is not contracted from a toilet seat. Neither is it contracted by kissing. So when patients come and say things like that, it's not true. You know, I sat on the toilet seat and now I have syphilis. It kind of all depends what you were doing on the toilet seat, but that's beside the point. So vertically, it's transmitted it's a transplacental transmission. Though it is rarely transmitted via contact with infectious lesions, it still does happen. It's associated with transmission is associated with earlier maternal stage of the disease, and that stands to reason because we said the first and second stages of this disease are the most contagious stages of the disease. And of course, the higher the maternal disease titers. Similar to people who are HIV positive, the higher the viral load, the more likely they will transmit to their infants. If you have high titers, then more than likely you will transmit, and you're untreated, you will transmit to your child. On transmission, even though the earlier the maternal stage, there's a higher risk of transmission, I want to reiterate again that transmission can occur from mother to child at any stage of pregnancy. So there has been an update in the guidelines of syphilis screening. The previous CDC guidelines said that all pregnant people had to be screened at their first visit, and then there was a retest at 28 weeks and at delivery based on whether we considered the person to be at increased risk. And of course, increased risk was, late or no prenatal care, whether they'd been a substance abuser, whether they had multiple STIs, whether they were HIV positive. But that has all changed. And as of April last year, the updated guidelines is universal screening at the first visit, in the third trimester, and again at delivery. So that means that all pregnant women should have syphilis screening 3 times during pregnancy, and the last time is at delivery. If you remember, there was that slide where I showed you in the very beginning where it said that about 40% of the cases in 2022 were actually in the Americas, and a large percentage of those cases were actually in with our neighboring country, Brazil. And because of this, Brazil actually changed their guidelines. And I'm just putting this in here to show how seriously people take congenital syphilis and syphilis in pregnancy. They do a reverse algorithm. So they do the treponemial test first and then the non-treponemial. And as far as the Brazil guidelines go, they have now changed it. So if the first test is positive, they don't bother to wait for the results of the follow-up test, the confirmatory test. They go ahead and treat all pregnant women. So immediate treatment with benzathine, benzopenicillin is recommended after just one reactive test for syphilis. They take this very seriously because they have had a very high increase in congenital syphilis. So timing is really important because the earlier we treat, the less likely we will have congenital syphilis. So about 70% of congenital syphilis stillbirths are likely avoidable if treatment is provided by or before the 21 weeks, gestational weeks. So it is really important to screen mothers as early as possible, get them into antenatal care as soon as possible, and treat them as soon as possible. The earlier we treat them, the less likely it will have any effect on the children. So for prenatal syphilis treatment, it's very similar. We use the same medication. It's 2.4 million units IM once. Some experts do recommend a second dose 7 days after the initial dose. If it is latent or unknown duration of syphilis, then of course we do the weekly doses for 3 weeks. It is important, as Dr. Ned told us, to follow up with all of our patients, and follow up after treatment in pregnancy is extremely important. So a repeat RPR is advised 8 weeks after treatment. But if your patient comes to you after their 24 weeks gestation weeks, then it may not be necessary for you to do another one at 8 weeks, and you can just do it at delivery. But you need to do repeat tests after you conclude your treatment, because you're looking to see how successful it is. You're looking to see whether the titers are going to drop. You're looking to see that it drops at least twofold for you to consider that this is a successful treatment. It is important because some people get reinfected in pregnancy. So it is important that you do follow up, you call them in, you make sure that you do another syphilis test. And if you didn't get a chance to do a second one, you make sure that you do it at delivery. And this is just a graph showing you more or less what we just talked about. So I'll skip over this. There is, of course, something that is called the Yarish-Herxheimer reaction that I'm sure we have all heard about. So this is a reaction that can occur. It may precipitate fetal distress, premature labor, during treatment, especially in the second trimester. This reaction is an acute febrile reaction. It's accompanied by headache, by generalized muscular aches and pains, and it can occur within the first 24 hours after the initiation of any treatment, syphilis treatment. It is a reaction to the treatment, and it is not an allergic reaction to penicillin. You should tell your pregnant patients about this, but this should not be a reason for you not to treat your pregnant patients. But you must inform them about it. You must inform them that they can use antipyretics if they start having contractions or they go into early labor, premature labor. They must go immediately to the emergency room. So we're going to just talk really quickly, because I know we're running out of time, about the management of the babies that have been exposed to syphilis while they were in their mother's womb. So the syphilis serologies that we do at delivery, we do the non-treponemal tests, so either the RPR or the VDRL. You need to do both the birthing parent and the infant titers at delivery. Remember, we said the last RPR or the last syphilis test is done at delivery, because you're going to do it at delivery for the mother and for the baby. You're going to perform the same test on both, and they should be drawn more or less at the same time. So if you're doing the RPR on the mother, you're doing the RPR on the baby. If you're doing the VDRL on the mother, you're doing the VDRL on the baby. We do not do the treponemal test, because we said that that's an antibody test, and we know that it will always be positive. And as we know with HIV, the baby will test positive for antibodies too. So that doesn't really help us. So we don't need this when we're screening the infant. And then just a quick slide about the response, the RPR response to treatment. So we look at these titers from 1 in 1 to 1 in 128, 1 in 512. So titers should decline at least fourfold after proper treatment. This decline can take a while. It can take from a few months to even up to 2 years. So what we're looking at by fourfold decline is that it goes down 2 dilutions. So if you had a 1 in 64, then we do expect it to go down to 1 in 16 for us to consider that this was a successful treatment. If you have a patient who had a 1 in 2 when you screened him the last time or her the last time, and the next time you test them it's gone up to 1 in 8, it means that that is a reinfection or a new infection. So this is important for us to understand when we're looking at titers and we're looking to see how successful our treatment has been. So for the next few slides, I'm actually going to do a few cases, because I feel like that helps us all to understand. So case one is a 28-year-old previously healthy woman who presented for her first ANC visit at 16 weeks. Her initial syphilis screening was negative. At 24 weeks, she came back to the clinic because she had a generalized macular papular rash. She was initially diagnosed as having a viral rash. At 34 weeks, she was admitted for premature labor and was diagnosed with syphilis in the labor room. Her RPR at delivery was 1 in 64. So what is important to note is though she had a rash, and remember I said every rash, unless you can prove it otherwise, should be considered a syphilitic rash. So even though she had a rash, at 24 weeks when she presented, there was not a second syphilis test that was done. And she didn't receive any education about syphilis or how to protect herself. Her baby, a little baby boy, was born with snuffles and a rash on his palms and his soles, and he had hepatosplenomegaly. His RPR was 1 in 512, and he was diagnosed with congenital syphilis. So this is a case of a baby who has proven, proven, or highly probable congenital syphilis. And any neonate that has any one of the following: an abnormal physical exam that is consistent with congenital syphilis, the snuffles, the rash on the palms and the soles of the feet, the, um, the, the hepatomegaly, those would be things that are consistent with congenital syphilis. Or if the baby has a non-treponemial titer that is fourfold higher than the mother's titer at delivery, which this baby did. Mommy was 1 in 64, baby was 1 in 512. Or if the baby has a positive dark field test or a PCR, then if the baby has any one of those, this baby is considered to have congenital syphilis. And for this baby, you have to do a complete evaluation. You have to actually do a CSF analysis, you do a complete blood count, you can do chest radiography, long bone radiographs, liver function tests, neuroimaging, and you can do ophthalmological examinations, do hearing tests. You have to do a complete and full evaluation of this infant because we know congenital syphilis can be debilitating. It can have effects on their nervous system, on their eyes, and and also on their hearing. Treatment for these children is actually aqueous crystalline penicillin that is given IV. The last time we did this presentation, we were told by the neonatologist at Georgetown Hospital that it's important that these things are clearly marked because benzathine penicillin that we use is given only IM and never IV. So these children get aqueous crystalline penicillin. It's given um, IV every 12 hours for the first 7 days, and then every 8 hours thereafter for a total of 10 days. If more than 1 day of therapy is missed, then the entire course should be restarted. So if you give it on day 1 and then somebody drops the ball and doesn't give it on day 2, then it's not day 3. It's actually we're restarting at day 1. Same thing, if somebody drops the ball at day 5, then we don't go on to day 6. We start at day 1 again. So the entire course has to be restarted. It is really important because with a child that has proven congenital syphilis, even though we may do our best and give them everything that we know we can give them, they can still have long-term complications. If we don't have aqueous crystalline penicillin, or we don't have a place to admit this child to do IV medications, you can use procaine penicillin. That is given IM, not IV, and is given in a single daily dose for 10 days. And again, if 1 day is missed, then we start counting all over again. Sorry. So this is our next case. Our next case is a young lady who delivered a healthy male infant at 37 plus weeks. She was treated for syphilis in a previous pregnancy 3 years ago. Her documented RPR 3 years ago was 1 in 8. There was no follow-up RPR that was done for her. And her RPR now at her present visit was 1 in 4 at her first antenatal visit. And there was no treatment given to her, and her RPR at delivery was 1 in 4. Her newborn had a completely normal physical exam, and his RPR was 1 in 4. So what should we do with this baby? No treatment because the mother wasn't treated. We retest the baby in 4 to 6 weeks, or should we treat the baby? So first, any seropositive pregnant woman, and seropositive I mean syphilis positive pregnant woman, should be considered actively infected unless an adequate treatment history is clearly documented and sequential antibody titers have declined. So something that was documented 3 years ago that was 1 in 8 with no sequential titers, and now we have a titer of 1 in 4 tells us nothing, really doesn't tell us anything. So this mother should have been treated. So this baby now, even though he has a completely normal physical examination, he falls into the category 2 of possible congenital syphilis. And that is because even though he has a normal physical examination and his titers are equal to, or equal to, in this case, equal to his mother's titers, or if they were equal to or even less than fourfold of the mother's titers, but because his mother was not treated, or if the mother was inadequately treated, or if there was no documentation of her ever being treated, if the mother was treated with a non-penicillin G regimen, or if the mother did receive the correct treatment, but it was given less than 30 days before delivery, if any one of these is true, then this baby would be considered to have possible congenital syphilis. And again, a complete and thorough evaluation is recommended for this baby. The treatment for this baby is similarly, it's the same aqueous crystalline penicillin given every IV every 12 hours for the first 7 days, and then every 8 hours for the remaining 3 days, or it could be procaine penicillin that is given IM in a single dose for 10 days. If for some reason you cannot keep this baby for 10 days, or you have to send this baby back somewhere that you're not sure what will happen to the baby, you can give the baby a single dose of benzathine penicillin G IM. But before you do this, you must make sure that you did a thorough evaluation. Everything must be normal. The CSF examination, the long bone radiographs, CBC should be normal. If anything is abnormal, then you have to keep that baby for 10 days and do a 10-day course of penicillin. Case 3 is, the next case is a 30-year-old housewife. She's already had several pregnancies. She enrolled in ANC at 11 weeks. She was HIV negative. She had an RPR at 1 in 16. She was treated with the appropriate regimen, and her RPR at 24 weeks was 1 in 4. Her RPR at delivery was 1 in 1. Her baby had a normal physical exam, and baby's RPR was 1 in 1. So what do we do here? Do we just reassure the mother no treatment needed for the baby? Do we repeat the serology at 4 weeks? Or I don't know. I don't know what to do. We'll look for somebody and ask them. So this baby falls into category 3, which would be less likely that this baby has congenital syphilis. And the babies that fall into this category are the babies who have normal physical exam. Their non-treponemal titers are equal to or less than fourfold of the mother's, and the mother was treated effectively and appropriately for her infection, and the treatment regimen was initiated more than 30 days before delivery. She was treated very early in her pregnancy, and the mother has no evidence of reinfection or relapse, and that is because we did sequential titers and we saw they dropped all the way down to 1 in 1. So we don't, even though we don't need to do any evaluation for this baby, treatment is still recommended. And we do give this baby 1 dose of benzathine penicillin GIM. We do it as a single dose. And this is my last case. This is a 24-year-old prima gravida. At her first OB/GYN visit at 12 weeks, her RPR was 1 in 4 and her TPPA was positive. She had been in her present relationship for about 14 months. Both she and her partner tested positive for syphilis 6 months ago. She was 1 in 64 at that time. Her repeat test at 28 weeks is 1 in 4. Her TPPA is positive, which is what we would expect. Her test in labor and delivery, hers was 1 in 2, and her neonate was non-reactive. So this is someone who was treated for syphilis prior to her pregnancy. So she had a 1 in 64. When she came into antenatal care at 12 weeks, her RPR was 1 in 4. So that shows that she was successfully treated and she was probably not reinfected because she went from 1 in 64 all the way down to 1 in 4. Her repeat titers at 28 weeks were still 1 in 4, and then at labor and delivery was 1 in 2. So again, she was successfully treated before pregnancy, and there's no sign of a reinfection or of a new infection. So her baby falls into the category of a baby who's unlikely to have syphilis. So he has a normal examination, and his mother was treated adequately before pregnancy, and the mother's titers have remained low and stable before and during pregnancy. So for this baby, we don't recommend any treatment. We don't recommend any evaluation. If the baby had had a reactive non-treponemial test, his was non-reactive, then we would recommend that you do a follow-up visit with the baby. Or you could, if you're not sure if the baby would come back for a follow-up non-treponemial test, then it would be wise to give this baby a single dose of benzathine penicillin, because you're not sure if you're going to be able to follow up with this baby. This here is an algorithm for the congenital syphilis. It's kind of like a busy slide, but it actually has everything that we discussed here, and it's actually a good algorithm, so I do recommend it. And I'm going to leave these slides with Dr. Chin, and she can probably pass it on to you. This has the first, second, and third scenarios, not the fourth scenario, the baby that doesn't need any treatment. Before I close, this is what is really important, the follow-up of the neonate. So you should do a follow-up, an exam, and a follow-up RPR every 2 to 3 months. You expect the titers to decrease by 3 months and to be non-reactive by 6 months. If you have a child that has a persistent RPR or VDRL past 6 months, you may need to consider another LP and maybe retreatment and possibly have a consult with an ID specialist. If the baby was seronegative at birth, you should still check the baby at 3 months to rule out any incubating congenital syphilis. If the initial CSF of any baby is abnormal, you do not need to repeat the LP unless the baby has a persistent RPR or VDRL past 6 months, and that's when you would consult with ID about that. It is really important to follow up. So sometimes the babies that you see or the children that you see going into the pediatric wards with congenital syphilis that are delayed late, it is possible because they never had follow-ups. We never did that 3 month checkup. We never checked to see if their titers were decreasing. follow-up is important. Syphilis can be treated, but we need to be aware of it, and we need to be literally having it on the front burner of our brains. So in closing, syphilis cases are increasing globally. We should screen all sexually active adults in primary care and acute care settings. Let us be aware of the symptoms and be aware of what are the appropriate treatment regimens. All pregnant women should be screened 3 times in pregnancy. No mother or newborn should leave any hospital without maternal serological status documented at least once during pregnancy. 3 times is the best, but if you have someone who just turned up to deliver, they cannot go unless you have screened them. Treatment and follow-up of newborns affected by syphilis is crucial, and remember, syphilis is preventable and treatable. These are my references, and thank you very much. Happy Easter to all of you.
Thank you so much, Dr. Mutu, for such a well enlightened presentation. I know, like myself, everyone was paying keen attention. It is information that often is well researched, and so it is of benefit to all of us. There are just about 4 questions, Doc. I know we're past our time. I'm going to ask your indulgence, with your permission, if we can try to tackle 3 of those questions.
Sure, sure.
So first, commendation, great presentation. What protocols can we follow for our pre and postnatal mothers who are treated but continue with high titers?
So, excellent question. So the high titers, once the titers are not going up fourfold, we don't have to think of reinfection or a new infection. Some people can remain what we call serofast, so they stay at 1 in 4 or 1 in 8. It doesn't go any higher. You don't need to retreat them unless it goes up higher. However, if they were always 1 in 8 and you treated them and it never went down, then a retreatment might be necessary, especially if they're pregnant.
Thank you, Dr. Mutu. So just remember that terminology, serofast. Moving on to our second question. Great presentation. Uh, complete. I'm a midwife, and currently completed labs are ordered from a woman upon her enrollment into clinic, and her second labs are ordered between 30 to 33 weeks of gestation. I heard you mention that women are screened 3 times at admission, then at 28 weeks, then before delivery. My question is, are we working with screening for syphilis now at 28 weeks instead of 30 to 33 weeks?
So the first screening is done at initiation or at enrollment in clinic. The second one should be done in the 3rd trimester. So whether we're going to do it early in the 3rd trimester or late in the 3rd trimester, I guess that varies depending on when the woman comes to clinic. But it has to be done in the last trimester. So the last trimester would be from 7, 8, or 9 months. And the third one has to be done in the delivery room because it has to be done the same time with the babies.
Thank you, Dr. Mutu. And can a pregnant woman use pills treatment even if RPR is non-reactive as prevention?
So the woman has I'm not sure if I understood it correctly. So the woman has a negative RPR.
Yes, and they're talking about
You mean like preventive treatment for syphilis? No, we don't really have any syphilis preventative treatment. I mean, I guess just safe sexual practices would be the best, and also it would be it would be a good practice. I know we don't do it to screen the partners of women even if they are testing negative in at their first test, just to make sure the partner doesn't have syphilis, because then they may get it from the partner at the second test.
Thank you, Dr. Mutu. And I'll take the last question. It's a question: should persons get sick leave if they're placed on post-exposure prophylaxis? And so, based on our national guidelines, Uh, moving from using a triplet to TLD, there is minimal side effects for from the tablets, and so we don't generally give sick leave for the use of the tablets or any side effects, but of course that is dependent on the nature of the injury. I mean, if it's a large gash and you're bleeding or whatever, and it's something that requires that you get sick leave, then that would be dependent on the nature of the injury and the clinician. But for the use of the meds and side effects, absolutely no. Uh, there's no other questions, and so if since that's the case, I'll hand over to the our moderator, Dr. Chin.
Thank you very much, Dr. Mutu and Dr. Jagnaran. Again, to Dr. Mutu, many thanks for your presentation. It was very clear, but indeed thought provoking, and you've actually inspired us to you've inspired us to definitely take a step back and actually realize that a simple test as syphilis can make the difference between having a healthy pregnancy and a healthy baby, or a lifetime of possible complications, or even loss of that pregnancy and loss of life. So thank you very much for that presentation. There isn't anything really else that I can add to the presentations that we've had from both Dr. Nan and lastly from Dr. Mutu. However, I will leave some food for thought with my colleagues here still on the seminar here with us. And it's one for our presentation on PrEP and NPEP. And it's to realize that every time a person leaves your clinic without learning about PrEP or PEP, we actually miss an opportunity to prevent HIV. So we should ask ourselves as healthcare providers, in whatever category that you're offering services to the persons that visit your health facilities, what are you doing as a healthcare provider to actually prevent HIV? And as I said, as it relates to the prevention of vertical transmission of syphilis and any other form of sexually transmitted infection, we should really see how best we can aid in promoting healthy pregnancies, having safe deliveries for our mother and unborn babies. So thank you very much for being with us today. Enjoy the rest of your evening and happy Easter to yourself and family.
Guys, you don't need to actually worried about your CME. A certificate will be emailed to you. Happy Easter, everyone.